Thank you, Susan. Actually, that was too kind of an introduction. But what I'd like to talk about today is probably the number one question that we get asked. It is almost asked at every new patient visit, and is not that simple to really understand just initially. So this is the question of Alzheimer's disease. Is it Alzheimer's disease or dementia? And then kind of as a subtitle, I put, does it really matter what it is? And so I hope by the end to kind of convince you it does matter, and that the terms should not be used synonymously, and that this field actually is becoming more and more understood as we go on. So this is the question, does dementia equal Alzheimer's disease? And the first thing that's important to remember is that dementia is an adjective. It's a descriptive term. So it's used to describe any individual who's declined in their memory and other mental abilities to the point that's affected their function. And then the third part that's listed there is that it has to be in the absence of delirium, meaning that you can't make a diagnosis of dementia if the person is acutely ill and may have another process that's making them confused. So that's dementia. So it's a descriptive term. So an analogy of that would be if I was to tell you I have a headache. Well, you'd understand that my head hurts, but you wouldn't know if it was from a tumor or from a migraine or from tension or from medications, because a lot of things can cause headaches. Similarly, a lot of things can cause dementia. Alzheimer's being, of course, probably the most common. But there's other things that cause dementia as well. And you don't have to look at all the kind of specifics of this slide, but this is from a study where they looked at individuals who were followed during life, and then we looked at the brain at autopsy. And these are people who have dementia. And as you can see in the middle, Alzheimer's disease made up the vast majority of those cases. But on one end of the spectrum, you had people who had vascular disease, so that's strokes. And that was the cause of their dementia. And on the other side, there's people who have Parkinson-like diseases. We call them Lewy body disease. And that's the cause of the dementia. And some people have a mixture of things. So just keep in mind that dementia is just this general term for a person who's declined in their memory and other abilities that affect their function, but does not tell you anything specific about the cause. And that's what you really want to know. So what's Alzheimer's disease? So that is a disease. It's a disease that affects the brain, almost entirely affects the brain. And it's due to an accumulation of a protein that's called beta amyloid. So this protein, we all have some of it, but in Alzheimer's disease, either because it's overproduced or mechanisms that usually remove it fail or are not as efficient, the amyloid builds up. And we think in some way that causes first disruption of the normal actions between cells, and then eventually the cells die away. So Alzheimer's disease is a progressive disease that leads to dementia. What we know now, of course, is that you can have Alzheimer's disease and be normal. I might have Alzheimer's disease because we know the disease begins in the brain 10 to 20 years before you even have any symptoms. So some of us may be harboring Alzheimer's disease now. We're not demented, but we may have the disease. So the answer to the initial question, does Alzheimer's equal dementia? And the answer is no. So one's a broad term, one's a specific disease. Now, this slide actually kind of in a very schematic way indicates really how we view Alzheimer's disease to be. That is, it begins in the brain, again, when you're completely normal, and this amyloid starts to accumulate. And then at some point you do start having symptoms, and the symptoms are generally memory, loss of memory, can affect behavior. Sometimes people become apathetic, they lose interest, they become irritable. May have some problems with higher levels of thinking, decision making, judgment. But these are very mild symptoms, and sometimes they're mistaken for normal aging. Certainly, of course, as those symptoms progress, then it becomes obvious it's not normal aging, and people often take an interest in it. Unfortunately, in our medical system, we've spent most of our time dealing with dementia. So people have made it to the point where they're really having problems, and now we start paying attention to it. But in the future, as we go forward, and actually what's happening here already at the Cleveland Clinic, is there's this big push to recognize the disease earlier, because that's probably when treatment's going to be most effective. So right now we're treating the last third of the disease, but what we want to get is to the point where we're treating actually earlier and earlier stages.
Do you know what contributes to the development of the amyloid?
Yeah, the question is what causes the amyloid to develop or even accumulate. And what we think, again, is there's two possible ways. So certainly, probably in families where there's a strong genetic factor, it may be that you actually overproduce amyloid. So they're actually producing too much and you can't remove it fast enough. In other cases, probably more commonly as people get older, we have a difficulty clearing it out of our system. So it backs, it's like a sink, it stopped up, it just kind of backs up and accumulates. So those are the theories. And by the way, with questions, just for our other sites and such in the recording, if you can keep your questions to the end, then that way just write them down so we can all take them all at the end. Now this slide, it actually indicates how early we think things change in the disease. Because this is looking at a group of individuals at the far end of the graph where it says 0. That's the time where a person's actually diagnosed as having Alzheimer's disease. But you can look back, and if you focus on the red line, and these are tests of memory. So you can see up to 7 or 8 years before somebody is diagnosed with Alzheimer's disease, there are changes happening with memory. So this is a very slow process that begins many, many years before somebody actually usually gets a diagnosis. Now, the other part to this is the not assuming, if you have memory problems, that it's due to Alzheimer's disease, because other things can cause memory problems. And this is just a list of some of the things that can do it. So it could be vitamin deficiencies and depression and medications and strokes and all these various things can give you a dementia. They can cause the same type of symptoms as Alzheimer's disease. So how do we differentiate these various potential causes? So we have tests, and it's important to point out, I think, for everybody, that if somebody is starting to have memory problems, that the first step is really getting a good, thorough examination. So that usually means getting certain blood tests to be sure there's nothing metabolically out of whack in your system, having somebody review your medications to be sure you're not on any medicines that can cause memory problems, and then usually to get some type of imaging of the brain. So the MRI scan is the common one we use. So unless you have a pacemaker or something that precludes you from it, in which case you'd have to get a CT scan of the brain, the MRI scan is a common tool, very useful. However, it's not diagnostic of Alzheimer's disease. So when the doctors order an MRI scan, when we order an MRI, we're not using it as a diagnostic tool for Alzheimer's disease. We're using it as part of the evaluation to rule out, to be sure there's nothing else that's going on, strokes, tumors, things like that. Now, it turns out there happens to be one specialized part of an MRI scan. We do it here at the Cleveland Clinic, although I don't think it's done anywhere else in town. which is called volumetrics, where we can actually measure the size of different areas of the brain. And we know what's normal for various ages. And so we can see if there's more shrinkage, particularly in the memory area, than what you would expect. And that can be useful to help confirm a diagnosis, but again, there's nothing on the MRI scan that's strictly diagnostic of the disease. PET imaging is a different type of test that looks at brain cell activity. Again, that's not an uncommon test to use. Spinal fluid tests are sometimes done. This is not done on everybody, but if we suspect there might be an infection or some other process, inflammation in the brain, the spinal fluid is useful to look at. We sometimes will do that test if we think a person may have hydrocephalus, to see if draining some of the fluid will actually help. Neuropsychological testing is just more detailed testing of memory and other abilities, and then there's various other tests too. So to make a diagnosis specifically of Alzheimer's disease, these are the criteria, and basically you can boil it down to three things. One is that you have to have cognitive impairment. Now, traditionally, we've said that for Alzheimer's disease, you have to have dementia. And as we've just talked about, that means already you're pretty far into the disease. So now there's new criteria that are being developed. But in general, the kind of traditional way is that you have to have a dementia, you have to have a course that's consistent with Alzheimer's disease, and that means early memory features, problems with short-term memory, and then other abilities start to drop off. But physically, people look good. So they don't have any problems with their balance, they don't have any problems with incontinence, they don't have seizures, anything like that, at least early on. And then we have to be sure nothing else that can otherwise cause the same type of symptoms is present. So that's where we exclude other things. So if you fulfill those three criteria, dementia, a typical course, and being sure nothing else is going on, then you're going to be right with a diagnosis of Alzheimer's disease most of the time. To do that, again, it doesn't take a lot. It's not so sophisticated. It's getting a good history, particularly from caregivers who are with the patient. There should be some type of cognitive testing. For many of you who've been here, we use a short test, a 30-question test called the MOCA. It's just a screening test, but it actually is a fast way to determine if somebody's really having problems. And then having the imaging and lab tests. So for most people, that's all you really need to do to make a diagnosis of Alzheimer's disease. There are certain blood tests that are part of the panel that we do. Oftentimes, these are part of a general physical exam that people get from their primary doctor, so we don't always repeat them, but we do want to be sure all these tests have been done, because you really can't make a diagnosis or be comfortable with it until you get all the testing done. Now, to try to diagnose the disease earlier, there's been a movement to change the criteria so you don't have to have dementia. And this is just, there's a couple of schemes that have been developed that we use as part of the research program here to diagnose Alzheimer's disease. So in almost all the schemes, you do need to have some symptom. So we're not, although we're getting to the point where we're hoping to be able to diagnose Alzheimer's disease before you even have symptoms, and I'll show you some information about that. There's still the feeling that it's kind of iffy to make a diagnosis, if you're completely normal. But if you're having symptoms, if you're having memory problems, either by itself or with other issues as well, and you have evidence by one of the tests that we have of Alzheimer's disease, then now the thought is that may fulfill the criteria for Alzheimer's disease. And I'll show you some of the things that we do for the test. So first is a volumetric MRI. So these are the MRI scans. We do it on all the patients that get scans here. And so we can divide the brain up into different areas. On the picture, you can see they're color-coded. So each area of the brain is a different color, and we can actually measure those regions. Here you can see pretty clearly the difference between Alzheimer's disease and normal. I'm just going to step around here. So this area here in the normal, I don't know if you guys can see it back here. You probably can't. This is the hippocampus, this little olive green area in here on both sides. And you can see it's kind of plump here. And you can see over at Alzheimer's disease, it's really shriveled up. So that's very obvious. You can just look at that and see that. But we can measure these areas and down to millimeters. And we can actually pick up very subtle changes in the size of these structures. Another technique that's commercially available that, again, we do here is called PET amyloid imaging. Now this is really neat because, and this is kind of the newest thing. So new, as a matter of fact, that insurances and Medicare do not cover it. And it's about $5,000 to do it. So yeah, so it's not, but it's a technique where we can inject, basically it's like a little dye or stain that we can image that attaches onto amyloid. So you inject the material, Elaine does that for us. You sit there and let it circulate in the brain. It attaches onto any amyloid that's in the brain, and then you can image it. So again, excuse me over here. On the top panel, this is a normal PET amyloid image. That is, you don't see pretty much any amyloid in there. The amyloid would be the yellow or orange. And here's somebody with Alzheimer's disease where the brain is chock full of amyloid. And you can actually, again, because amyloid builds up in the brain very early, we can actually use this technique to select out people who are at risk of progressing. So we have studies here. We have actually two studies. One that's using PET amyloid imaging for normal people. So we're taking normal people who have a positive PET amyloid image, meaning that they're likely to develop Alzheimer's disease, and actually treating them at that point. Treating them with drugs to remove amyloid from the brain. So that's where the field is moving. So it can be used kind of diagnostically if you're having symptoms and you have a lot of amyloid in the brain, that's Alzheimer's disease. Or possibly in people who are having no symptoms, in choosing people who are at risk. Now I say at risk because we know that there are people who are, for example, in their 80s that are normal. They scored normal on tests. They function normally. But they have amyloid in their brain, probably about 30%. And so we don't know if that's just as you get older, if it's just normal to have some amyloid and it doesn't affect you, or if all those people, if you follow them long enough, they'll progress. We don't know that yet. So we can't, in somebody who's not having symptoms, we can't, a positive test doesn't mean they have Alzheimer's disease. However, a negative test probably is pretty good evidence you don't have Alzheimer's disease. Because, again, it builds up very early, and if you don't have any amyloid in your brain, you don't have Alzheimer's disease. So we can use it as kind of a rule out, and so it's very useful for that. On the bottom panel here, just also to note, is the normal or the regular PET scan that we can order, that Medicare does cover. Now this looks for brain cell activity. So the two types of PET scans look for different things. But here on the bottom, oops, let me go back. Here we go. Here, the normal person, it's just flipped around. Normal activity becomes yellow and orange. So the warmer the activity, the warmer the color, the more activity there is in the brain. So that's normal to see that. And in Alzheimer's, you see less activity in the back of the brain. That's the parietal regions. And that's a very classic picture for Alzheimer's disease. So Medicare does cover that PET scan, and that can be very useful also in the diagnosis. We can measure amyloid in the spinal fluid. And it turns out that the amyloid actually goes down in Alzheimer's disease. So in the spinal fluid that circulates around the brain, the amyloid levels drop in Alzheimer's disease, presumably because it's being deposited in the brain. So if you, this just goes to show that on your left-hand side is a graph showing levels of amyloid in people with Alzheimer's disease versus controls, you can see there's a difference. And on the other side, on the right-hand side, we're looking at a different protein called tau, T-A-U, and that actually goes up. So if somebody has a profile that amyloid's low and tau is high, that is very, very suggestive or diagnostic of Alzheimer's disease. Again, Medicare doesn't cover that. So now what it turns out is that we have markers, even today, that pretty much can recognize who's at risk for Alzheimer's disease early in the disease, maybe before people even have any symptoms. And that gives us a great tool in trying to develop treatments that we can start very early and hopefully delay the progression of the disease. This cartoon or this schematic, it just shows the various tests and at what point in time they change. But you can see pre-symptomatic, very early, you can measure changes in amyloid. And it's actually very later in the disease that people start having the symptoms. Now I want to just go through kind of the various other things that can cause dementia. So because we talked about Alzheimer's disease. So I'm just going to go through a couple of these things. So one, and it sounds like Dr. Liziero is going to talk about this next week, and that's frontal temporal dementia. So frontal temporal dementia is a different condition than Alzheimer's, whereas Alzheimer's disease tends to affect the memory area and the back of the brain, which you can see here, the area in the back, which has less of the activity. In frontal temporal dementia, it's just the opposite. It's a disease that affects the front part of the brain. Now, as it turns out, it's more complicated than that because there's various subtypes or varieties of frontal temporal dementia. The most striking one is what's called the behavioral variant. And this usually affects people in their 50s, so young. And it doesn't start out so much with memory problems, but rather behavioral changes. So people become socially inappropriate, disinhibited. They don't have any empathy for anything. They have this kind of change in behavior. They're very childish in some sense. And then over time, memory becomes affected too a little bit. But the striking thing is this personality or memory change in somebody's 50s, late 40s or 50s. Remember, psychiatric problems, most psychiatric problems, if they're going to present themselves, do it at a younger age. It's very unusual for somebody who has no mental health issues to start having these changes when you're in your 50s or 60s. That just doesn't happen. Usually that's due to a disease process, another disease process. Now, there's other subtypes of frontal temporal dementia. There's some that affect language, primarily just language, your ability to come up with words and to understand words and so on. But the behavioral variant, of course, is the most striking, and that's what you see here. Probably the second most common cause of dementia, aside from Alzheimer's disease, is due to strokes. So we call that vascular dementia. And this picture just shows an MRI scan of an individual who's had multiple strokes. So those are the white areas that you see throughout the brain. It turns out that strokes can cause memory problems and dementia in a variety of ways. So you could either have a stroke, one stroke, but if it's kind of right in the right area, it can affect your memory. Or you could have had a couple of big strokes, and they just pick off enough of the brain, and it can affect your memory. Or sometimes it just affects the very, very small blood vessels, and it's more of just a progressive decline. You don't see any big stroke-like episodes, but the person just kind of progressively gets worse. In almost all those cases, there's usually some physical features with it. I mean, it's unusual just to have memory and nothing else. So people they might have some slurred speech, or they might have weakness on one side, or they may have problems with their balance, or they may have incontinence. So there's usually something else to tip you off that it's vascular disease. What we commonly, or not, let's say not uncommonly see, is people who are referred here and have been told they've had mini strokes, the mini strokes. And that usually comes from somebody doing a scan on them. And the radiologists report, they usually say high signal lesions in the white matter consistent with microvascular disease. So somebody reads it, the doctors read it and say, oh, well, you've had mini strokes. In most of those cases, actually, it's probably not mini strokes. It probably could be Alzheimer's disease. And then the scan was just kind of misinterpreted. So you do have to be careful. And I would suggest that if you see a neurologist, that they look at the picture themselves and not rely, because sometimes you're not quite sure what people are reporting. And Alzheimer's disease anyway can coexist in a person who's had strokes. I mean, they're both common parts of aging, or common with aging. So, but certainly the importance of the vascular dementia is that it's preventable, or once recognized, you can actually prevent further strokes. So if we see somebody, whether they have Alzheimer's disease with strokes or just strokes, there should be really, I would say, an aggressive effort within reason to try to prevent further strokes, because that's actually a treatable condition. You may not be able to reverse it, but theoretically, if you had appropriate interventions, you may be able to prevent it from getting a lot worse. Another diagnosis that actually got into the media, I don't know, 4 or 5 years ago. Although, and we have people that always inquire about it, something called normal pressure hydrocephalus, or NPH. So this condition is caused by actually a buildup of fluid in the brain. So the ventricles are the areas of the brain, the fluid circulates around. If there's some obstruction to the fluid getting absorbed, again, it's like a sink that's stopped up. The fluid backs up and the ventricles get big. And if they get big, they start squishing the brain and start stretching the fibers. And there's 3 components of it that are very characteristic. So one is incontinence. The second is kind of a gait disorder, walking problem. Often can look like Parkinson's. And the third, of course, is memory. But interestingly, the memory isn't usually the initial or the main feature. The initial part for most people is either the gait disturbance or the incontinence. So if somebody comes in and they said, yeah, he's had memory problems for 5 years and now he's starting to become incontinent, that's probably not NPH. How do we diagnose it? Well, it's through the scan. So here, I mean, this is, again, you could see the obvious difference between the big ventricles here and a normal brain. But sometimes it's not that obvious. So the ventricles are a little big, and then you're trying to decide, well, are they big because the fluid's building up, or are they big because you're just losing brain tissue and the whole brain is kind of shrinking? So it's not always an easy diagnosis to make. And there's probably, it's more common that the stroke issue, the vascular dementia, causes incontinence, gait disturbance, and memory problems than normal pressure hydrocephalus. However, if it's suspected, then usually we do some type of test to drain the fluid and then see if the person gets better. So you can drain the fluid with a lumbar puncture. That's an outpatient deal. You just drain some of the fluid and see if they get better. Or sometimes you could actually be put in the hospital, and the neurosurgeons can insert a drain that drains the fluid kind of constantly for 24 hours, and then you monitor the response. Again, it's not a very common condition, but frankly, if it's there, it is a treatable condition. You can actually reverse it. Another disease that's very common, probably, again, would be a second or third on the list, maybe behind the strokes, is Lewy body disease. Now, Lewy bodies are these structures in the brain that we see microscopically, and they are the hallmark of Parkinson's disease. So our thinking now is that Lewy body disorders, there's a spectrum. So on one end of the spectrum are people that have garden variety Parkinson's disease. So they start out, they have the tremor and they're a little bent over, they shuffle. And then over time, 10 years, whatever, they start having memory problems and kind of go on. On the other end of the spectrum are people who actually begin more with the memory problems, and we have kind of mild Parkinson features. Yeah, they're a little slow, they're slowing down a bit, their balance isn't quite as good. And then as that progresses, they can develop more Parkinson features, and the memory problems get worse. One of the tip-offs to Lewy body disease, the latter one, the one that starts with the memory problems, is that commonly they'll get hallucinations very early in the disease, even when the memory is relatively mild. Memory loss is mild. So hallucinations, they almost all have what we call REM sleep disorder. REM sleep disorder is like when you're in your REM sleep, that's your dream sleep, that you actually act out on your dreams. Swing, talk, punch. And that's because we all normally, during your dream sleep, your REM sleep, there's mechanisms that prevent you from moving. Also, all of us would be doing that during your dream state. But for whatever reason, in this disorder, and it's very common, people lose that mechanism that inhibits movement. So they start moving, and they're punching their bed partner and so on and so forth. So that's a very, it's not diagnostic of this, but it's a very common feature. So hallucinations, the sleep disorder, the mild Parkinson features, these are all things that should at least make us think about this Lewy body disease. And it's important because these individuals can be very sensitive to some of the drugs that are used for hallucinations. In fact, you can kill people with them. And on the other hand, they may respond even better to some of these Alzheimer's drugs. So it is important to recognize that it's a different entity than just Alzheimer's disease. Finally, there's what we call prion diseases. This is like mad cow disease. We call it Creutzfeldt-Jakob disease. It's a sporadic form of it. So these are rapidly progressive dementias. So from the time of diagnosis to death is like 3 to 6 months. Very rapidly progressive. And they have other neurological features, usually with the visual changes and balance problems and so on and so forth. Fortunately, they are rare. The chance of seeing it is like 1 out of a million. So they're not very common, but they're devastating if you have them. And they're conditions that we don't have any treatment for. There are certain features that are diagnostic of them on the MRI scan. And on this, it shows an EEG of the brain waves. So they can be diagnosed. It's just that we really have no treatment for it. It's all supportive at this point. Now, I just want to mention 2 other things. So those are all kind of the big diseases. But the first stop at any evaluation of memory problems is medications. So I just want to make a pitch about medications. And these are medicines either people have given, other doctors have given you, or over-the-counter medications. Because there are certain medications that will make memory worse. So what are the common ones? Well, over-the-counter, it's things like things that have Benadryl in it, Tylenol PM, or any Advil PM, any PM usually has Benadryl in it. And if you take enough of it, it'll affect your memory. I mean, particularly if you're older. I mean, so sometimes you could, yeah, it's fine to take it when you're 40, but if you're taking Tylenol PM when you're 80, that may be a different story. Then there are drugs that are used for incontinence. So oxybutynin is an example. That's ditropan. So that gets in the brain, and that can cause memory problems. Certainly the narcotics. Almost any narcotic can affect memory. Drugs that are in the Valium family, Xanax, Ativan, they can affect memory. Sleep medicines, which really are not designed to be taken every night, frankly. Those either Ambien and various other things, they can affect memory. Now, again, the good news is these are all temporary in the sense that if you stop the drug, your cognitive function should come back to normal. So it doesn't cause permanent damage. But frankly, as long as you're taking these drugs, they can affect your performance, they can affect your balance, they can affect a lot of different things. So first stop is looking at the medication list and just being sure that nothing else that you're taking is causing the problem or the person you're taking care of. The other big one is depression. So depression can affect memory. What's somewhat confusing about that is that some of the early symptoms of Alzheimer's disease can mimic depression. So people can lose interest in things, they withdraw, they become apathetic, and sometimes they're thought to be depressed. And you could treat that with antidepressants, but their memory isn't good. I mean, it doesn't help their memory. But there are people that have severe depression, and if you clear the depression up, their cognitive function improves. And so the drug issue and depression should never been missed. Never been missed. Actually, none of this stuff should be missed, but that for sure, because those are just two common things that happen. So finally, I'll come to the subtitle. So does it matter really to make a differentiation of what the cause of dementia is? Okay, so it's easy to know if somebody's demented because their memory's not good and it's affecting their function. But does it make a difference to go through all of this and see doctors and so on? And of course, yes, it does. And it does because, one, the treatments are different. How you approach somebody who've had strokes as the cause of their dementia is totally different than Alzheimer's disease, and maybe to some degree different than Lewy body disease. And certainly it would be different if it's caused by something you can reverse, by the drugs they're taking, by depression, and so on. The prognosis is different. So, because oftentimes we're asked, well, so what's going to happen next? How long is this going to last? When is it going to get really bad? And again, that differs depending on the diagnosis. So they're not all the same. And so knowing exactly can help us figure that out. And then finally, from the family's side, genetics. Knowing that can let you at least know what's running in your family. Alzheimer's disease is a good example. There can be a genetic component to it. If you have a family member, first-degree relative, that is a parent, brother, sister, with the disease, you're at increased risk. I mean, I'll just tell you that right off the bat. Now, I can't tell you exactly what your risk is, but there's definitely a genetic component, which, for example, with Lewy body disease may not be quite as much, although still there, but not quite as much. And certainly with strokes is not. I mean, certain things, and you may be predisposed to in the family, but a lot of the stroke risk factors are under your control. Smoking, control of blood pressure, control of diabetes, those kind of things. So you can control those things. So for all those reasons, we think it is important that you make a specific diagnosis. So I'm going to finish up here, and I think I just wanted to convey over the last few minutes, one, that Alzheimer's disease is not the same as dementia. So dementia is a general term. Alzheimer's is a specific disease. You can have Alzheimer's disease and not be demented, and you can have dementia and not have Alzheimer's disease. So they're different terms. And for us, what we really want to do is get to the root cause. What's the cause of the cognitive impairment? It's not good enough to say he has dementia. That's not a diagnosis. So that's one. And two is if somebody's having memory problems, then there should be this push to get a specific diagnosis and at least be sure that you've covered all your bases of other things that may be contributing. Because even if somebody has Alzheimer's disease, if their B12 is low, if they have sleep apnea, if they're taking other drugs, those things you can modify and improve a person's function. And as probably all you know, the biggest burden in terms of just caring for individuals who have Alzheimer's disease is related to their function. So the more impairment they have, the more resources that are needed for the caregiver. So the better function you can keep that person, the better it is for all of us, and for that person, of course, himself. Does anybody know what this says, by the way? I know you guys can't see it. So nobody reads Mandarin here, I guess. Yeah. Well, yeah. It actually says thank you. It says thank you in Mandarin. Yeah. That's what I'm told. I don't know. Somebody told me that. Yeah. So I'm going to finish up here. And Susan, should I take questions from our folks in? Elko. Okay. So for those in Elko, any questions?
Quick question. We didn't get the right handouts today, and for half the session we were watching the audience. So, when you talk about the amyloid, is that like a fluid that's built up, or is that something built up in the cells? What exactly is the amyloid?
Yeah. So the question is, although I'm sure you all heard it, what are we talking about when we talk about amyloid? So amyloid is a protein. So just as you have, millions of proteins in your body, these are kind of building blocks of the cells and of the metabolism. So it's like a little substance. And the amyloid, normally we have kind of ways to eliminate it because you don't want it building up. So we all have it. But in Alzheimer's disease, it seems to accumulate. And actually, one of the characteristics of the protein is it likes to stick together, or we call it aggregate. So it has this tendency, these little individual particles, they like to stick together. And then you get sheets of this. And these sheets are just deposited in the brain and somehow are injurious to the cells. They cause cells to first malfunction, and then eventually the cells die off. They actually just degenerate. So that's what amyloid is. It actually is first in the fluid. It circulates around, and then as it accumulates, as it binds together, it's deposited in the brain as these sheets of material, of gunk, that just kind of affect the brain function and eventually eliminate the cells. So the thought is, if you can eliminate amyloid while it's still fluid, before it builds up, you can actually protect the brain. And that's exactly the strategy that most of the research studies are focused on now. How do you get it out of the system, even while it's in its fluid form?
Can it be removed when it's solid?
So the question is, can amyloid be removed actually when it's in its solid in the sheets? Yes, it turns out you can. The problem is, and I'll just give you some background. One of the first treatments to try to get rid of amyloid was with a vaccine. So you can produce a vaccine that gets your body revved up to attack amyloid and then remove it from your system. So that the first vaccine study failed. They stopped it actually because there was a couple deaths because it was causing so much inflammation. And so the concern is once it's in the brain and kind of in that solid form, if you remove it, it may actually cause damage. You may actually cause inflammation in the brain and hemorrhage and swelling. So I think the target now is not so much the stuff that's actually accumulated. That may just be, that's like a smoking gun. It may just be there, but it's not doing anything. And it may be this we call it soluble protein, but it's the stuff that's floating around that you really want to try to get rid of.
What makes it build up?
I'm sorry?
What causes it to build up to start with?
Yeah, the question is, why does it build up to begin with? And again, there's two mechanisms. One is the idea that you produce too much of amyloid. So again, it's like an equilibrium. We're always producing a little bit of it, and we're always able to get rid of it. So it doesn't build up. There are some individuals, and this is usually due to genetic causes, that overproduce. Down syndrome is a good example of this, where all Down's patients will eventually develop Alzheimer's disease. That's because they overproduce amyloid. So they overproduce it. And they just can't eliminate it fast enough. For most people, though, it's probably an issue that something goes wrong in your ability to clear it out. And so then it just backs up. You're just not able to clear it out as much. And we can't tell you, I mean, for any one individual, we can't tell you what that mechanism is. So, but treatments are being developed actually to attack both ways. So some treatments are focused on trying to reduce production of it, and some treatments are focused on trying to get rid of it. And that's actually, most treatments are that way. You had a question, yeah?
How about studies where you can see the amyloids build up in the retina of the eye? Is that leading somewhere?
Yeah, so the question has to do with being able to actually image amyloid in the eye. In fact, there's been suggestions that that could be used as a diagnostic test in Alzheimer's disease. But I think the feeling is in the field is that that's not been proven actually to be accurate enough to use it as a diagnostic test. There's actually been a lot of things that have been looked at as possible screening tests for Alzheimer's disease. So there's been blood tests. We were actually involved in a study of that last year. There's been urine tests, the eye, smell tests. The problem with all these tests is it turns out they're just, they may look good if you're looking at a very kind of well-defined group of people who have the disease versus a very well-defined group of people who don't have the disease. But that's not the real world. And when you start getting people just with various diseases and other conditions, then they lose their accuracy. So at the moment, that's not being favored. Yes?
You listed thyroid as a reason for
Yes.
delivery problems. How is that? Is it people with low thyroid? Or
Yeah, so the question is, how does thyroid affect memory function or cognition? Either way, so and the most common way is low thyroid. So if the thyroid function is really low, I mean, it's like it slows down everything in your body, including your brain function. And yeah, if you treat it, they'll come back to normal. Hyperthyroidism actually also can affect cognition. So that too can give you confusion and poor thinking and so on. But probably the more common situation is hypothyroidism, too low, and that having to be corrected. But thyroid problems, particularly when somebody's kind of in the throes of getting everything adjusted, I mean, everything can be out of whack until it's stabilized. Yes?
The FAST scale that kind of does the trajectory for AD, could you use the FAST scale for Lewy bodies or vascular dementia, or is it just specifically meant for AD?
Yeah. So the question has to do with a scale that's been developed called the FAST. And that's just it's a staging system for Alzheimer's disease. It really was designed primarily for Alzheimer's disease. I mean, again, you can use these for anything because these staging systems, I mean, that's all they are, really. They're usually being developed for research purposes to kind of classify groups of people, And so it's not specific for Alzheimer's disease, although that's really what it was designed for. And I guess it gives you some sense of where a person is in the disease process, but in some sense you don't really even need it because you kind of can tell. And it's not like people go like today they're in one stage and tomorrow they're in another. I mean, it's a progressive process, so these things kind of blend into each other. Yeah, sure.
Not too long ago, there was a lot of publicity about the SAGE test from Ohio State University. How, you obviously don't use that, you use something else.
Yeah.
So how
Yeah.
reliable is that?
Yeah, so the question has to do with these kind of screening tests, cognitive screening tests. So one's the SAGE, we use the MOCA, the VA uses another one. So they're all fine. I mean, it's whatever your preference is. I think, you just have to take it the spirit for what they're developed, which is really just screening tests. So there's just screening tests to see, if you have cognitive impairment. And they do give you some idea if you follow it over time, because you can see how it changes. But that's about its limit. I mean, it's not specific for a disease. It just gives you a sense of where their general cognitive function is, and maybe can help a little bit in the actual diagnosis, because some diseases will, for example, affect visual spatial abilities. That'll be like hopping designs more than another. But I don't know if there's any one test has any superiority to another. Yes.
You mentioned the genetic factors for Alzheimer's. Is it the same for dementia? Certain patterns
Yeah.
or risk for dementia?
Right. So the question is how the genetics in Alzheimer's disease, how does that relate to dementia? And again, it depends the cause of the dementia. So the genetic factors for Alzheimer's disease are unique to Alzheimer's disease. And there are genetic factors, probably to a lesser degree, for Lewy body disease. And there are genetic factors that you'll hear about next week for frontal temporal dementia. So each disease probably can have their own separate genetic influences, but they're not the same for each different condition.
What would be a prime example of a dementia symptom?
Well, again, dementia is just, so we use the term more just descriptively for individuals. We almost always include memory as one of the symptoms, but they usually have to have other symptoms, so their judgment, their reasoning, their behavior, so they have to have other symptoms. And those symptoms have to be bad enough that affect your function. So if you have that, you have dementia. But again, that's not adequate. You really want to know what's the cause of it. What's the cause of the dementia? And that guides what you do next. Yes?
If you have the APOE4 gene, how can you get that tested from your doctor?
Yeah. So,
There's no other symptoms showing that you, in other words, pre-planning.
yeah. So the question has to do, speak about genetics, with this, one of the genetic factors in Alzheimer's disease, which is called ApoE. ApoE, there's several forms that occur normally in the population. And they're just numbered 2, 3, and 4. So you're going to inherit, well, two copies of E4, one, or ApoE, one from your mother, one from your father. So you can be 3, 3, you can have one, both of them being ApoE3, you can have 3 and 4, you can have 4 and 4. But 3, 3 is the most common. Those that carry E4 are statistically at a higher risk of developing Alzheimer's disease. But it's not an absolute risk. That is, you can carry E4 and never get Alzheimer's disease. So for that reason, if you're not symptomatic, you're not having symptoms, it's not recommended that you be tested. And in fact, I mean, who knows the way insurances deal with these things? I mean, if they know you have ApoE4, it may have some influence on long-term care. I mean, there may be other issues, but it's not recommended if you're not symptomatic, to get tested, because it's just, all you're going to do is be worried. I mean, in some sense. And in some sense, it doesn't tell you that much more, because if you have a family history of Alzheimer's disease, you know already you're at a higher risk. So it doesn't really, now, sometimes we use E4, that really the main purposes of it is, sometimes it can be used for diagnosis, but there may be a difference on how people with E4 respond to drugs. And that's being sorted out now. There's certain drugs that it may be, if you carry E4, you may be more sensitive to it. That is, it may have more of an effect, or vice versa. So I think we're using the genetics for that. Primarily, I think a lot of it is in terms of therapies and how different people respond to different things. Yes?
Last question, Dr.
Last question. All right, you get it.
Last not least,
Yeah, there you go.
could you just quickly address vitamin deficiency in that list?
Yeah. So the question is the issue of vitamin deficiency as a cause of dementia. So the big one is B12. So that's the one we always check for, because we know, at least historically, when people used to be B12 deficient a lot, that can affect memory. It can be, and behavior. So you can get psychiatric symptoms and so on. So that's the big one. And it's also, B12 is important because as you get older, you may still take enough in your diet. It just, you may not be able to absorb it, so it just drops. There is some interest in vitamin D. This is a little more controversial. That is, nobody really knows because almost everybody's low in vitamin D. I mean, almost everybody who's not taking vitamin D. So it's hard to know if that has an effect. That I would kind of put secondarily. Other vitamins we check for selectively. So for example, if somebody's a drinker, that tends to deplete thiamine, B1. And then you'd want to check B1, because that can affect memory. If somebody has had some gastric surgery, bypass surgery, whatever, we may want to look at other fat-soluble vitamins, vitamin E, for example. So those are kind of more selective. The B12 is probably the one that we check on everybody, and probably should be checked. And kind of the flip side, I just want to make an editorial about that, is, does it help to take more vitamins? So taking extra B12 or extra E or extra whatever. And in general, unless you're deficient in something, there's probably not a lot of evidence that taking a lot of it makes a difference. Having said that, there is one study that showed that vitamin E, actually at high doses, seem to, at least people with Alzheimer's disease of moderate severity, seem to slow functional decline a bit. Now, so that was, then we used to give vitamin E at 1,000 units twice a day, actually. We used to recommend it to everybody. Then there came a study that looked at kind of all these studies with vitamin E, because it's been tested in a lot of different things too, which suggested that actually for some people, vitamin E at 2,000 units a day promoted heart disease. So now we kind of backed off on the vitamin E issue. I mean, some people still can take it, but you just have to be careful at the high doses that's recommended. So my own feeling is if you're not deficient in something, it's probably not a great reason to take a lot of it. But these things should be checked to be sure you're not deficient.
Is B12 deficiency with a blood test?
Yes, the test is easily tested. So